Welcome to the Rumbidzai show. Salibonani, Makadini, hello, and welcome everyone. Thank you for joining us. We are filming from outside in the garden today. We've left our usual set due to the social distancing rules, and we are currently, we're complying with government guidelines and filming outside as we are allowed to in our new normal. So today we're talking about coronavirus and the experiences of some of Alima, Audrey, who was on the front line as a nurse. So I just want to welcome you. Welcome,
Thank you.
Alima, Audrey Mendoza. Mm-hmm. It's so good to have you on the show.
Likewise. Thank you. Thank you for having me.
Oh, thank you for coming on. Thank you so much. So could you tell us a little bit about yourself, your background, your in nursing, and just a little bit about you? Who is Alima? I know you as Audrey. So who is Audrey?
Some would like to think that Alima and Audrey are two different people, but that's a story for another day. Well, basically, I am a critical care nurse. That is my background. Not for long anyway, like you know. I just only recently qualified. So my background is purely from critical care. I'm full-time at the Queen Elizabeth Hospital in Birmingham. Which just so happened to be a COVID-19 hot zone. So yeah, that's basically it about me.
So when did you qualify exactly? You said you've just qualified.
Yeah, I did. December was when I officially finished my degree. So I didn't take a sabbatical or a gap year or anything like that. I just finished and I started. I already had a job offer anyway from the same unit that I'm working in right now. I started in January in earnest, and that's when I started as a critical care nurse.
Wow.
Yeah.
Mm-hmm. And how has your experience in critical care been? Perhaps just generally in your life, how was coronavirus for you? How was the experience? It's been described as unprecedented global pandemic. It's been really just something else for everyone. Mm-hmm. But for you, as someone in the front line, how has it been for you? What has your experience been?
There's been a whole mixture of emotions and feelings, to be honest, from right when we started. Because I can tell you this, nobody really knew exactly what we were dealing with. So we were kind of just learning as we got along. And if you were told to go somewhere, you just do it. Obviously, there were concerns about our safety. And to be very honest, these were addressed as soon as possible because they had to.
So the PPE scandal that was in all the press and everywhere, what was your experience? You said those concerns were addressed as soon as possible.
Absolutely. Because I can only say that because you'd find that you'd be dressing this way today and you come back in tomorrow and you're dressing in a different way. So this would lead me to believe that whatever concerns they were addressed, because people would complain that maybe the masks weren't sealing and then you get different masks or anything like that.
So did you find, sorry to stop you there, I want to see the picture of what it was like for you on a day-to-day basis. So how were you dressing? How were you dressing right at the beginning? And then what was the transition to when you felt that we're really safe? How did you start?
To be honest, there was never a time when you ever felt that you were really safe. I mean, you'd have a face shield on, you'd have a mask, you'd have everything, triple gloves, but you'd never really feel safe because you're dealing with COVID-19. Nobody really knows what it's going to do, how it's going to manifest, or, nobody really knew what was going on, to be honest. And we were kind of learning as we went along. So I wouldn't say you would feel 100% because the onus was up to you as a professional to keep yourself safe.
Yes.
They would offer recommendations. Don't do this, do that, do this, do that. And it was up to you to take it. For me, it was worthwhile just knowing that if I needed the help, it was there because it was. If you needed anything clarifying, there were people on hand to do that. PPE was, we had doffing and donning stations. The healthcare assistants role changed during that time. So they were solely responsible for dressing and undressing the people who were going into the COVID wards.
You mentioned that you had donning and
And
doffing.
donning and doffing, yes.
So the donning, what was that?
Donning was putting on the PPE.
Yeah.
So on a typical working day, you'd walk in into the hospital, go to the changing rooms, and change from your home clothes into scrubs. Okay. So once you get into the scrubs, then you go to wherever you're designated to be working in at that time. And no one day was the same. You didn't have a specified ward you'd work in. It was different every day. All the critical areas in at the QE were changed into COVID wards because we had so many patients coming in with COVID-19. So you never really know whether you're in area A, B, C, or D.
Okay.
Then when you got there, each area had a doffing and a donning station, depending on each individual setup. So you'd get in, and then we would have healthcare assistants there, and then they'll dress you. So obviously you'd go from gown to mask to this. And they'd make sure, because these were trained professionals on the doffing and the donning. So they would tell you exactly how to wear, because sometimes you can wear an item incorrectly, and then that affects its efficiency. So especially with the masks, there was a way of doing things, and they were there to tell you how to do it. At first they weren't, but as time went on, feedback from the healthcare professionals, and then they would be told to seal to everything, have name tags and everything. So you could tell the trajectory. It was improving each time. And it did make you feel safer, definitely.
That's really reassuring for us as members of the public to hear, because there was a massive, in the press, in the news, there was a lot of concern about PPE and the safety of healthcare professionals. So the fact that, as you've said, it changed as people were learning.
Oh yes, definitely.
That's good to hear. And you've said something that you felt supported. You felt that you had people to ask if you were not sure.
Oh yeah, absolutely. I mean, at that particular point, because we were having so many patients coming in, some staff had to be redeployed. So we had non-critical care staff coming in to work in critical care areas. They would have like short training, just so they know the basics. And then, at that point, critical care staff were sort of the senior supervisory members of staff, because then we'd oversee the other redeployed nurses. Yeah, because we had the critical care background, and that was pertinent for what we were dealing with at that moment, with ventilators and infusions and everything that was going on. So it worked in that way that obviously there were other senior members of staff available. There were doctors, consultants. Everyone was just pretty hands-on. We had proning teams, and
so I'll stop you there, because I want to go on to that a little bit more about what it was like on the ward. But what about generally in terms of perhaps for you as an individual, just as you as Audrey as a nurse? So did you have children? How did you manage the whole this crisis that you're dealing with at work, cross-infection at home? How did you manage that balance between home and work for yourself?
I have no idea. I just took each day as it came, because as a nurse, this was my profession, this is my job. I need to take care of these sick people as far as I'm able-bodied. For me, it was business as usual. And I just carried on. But obviously it was difficult in terms of childcare, obviously. But I found ways and means that kept me and my daughter safe as well. As far as I was concerned, I was terrified of obviously passing it on to my daughter.
I can imagine.
I did all sorts. I mean, I would bath twice a day, 3 times even sometimes. Thank God we had showers as well at the hospital. So as soon as you come out of the area, you could have a quick shower, which was very difficult for me and my hair, because I couldn't wash it every day. I had a very elaborate hairstyle. So that's why I decided to cut my hair.
So you cut your hair?
I did, yes, because then I could wash my hair every single time I had a shower. It was good for my peace of mind. It was necessary at that time, because the last thing I wanted to worry about was having my weave.
So no wigs?
Oh, definitely not. I haven't had a wig in a long time.
No weaves, no braids. So you just cut your hair?
And then just, got on with it. I don't think, the last time I cut my hair was about 20 years ago, I think.
20 years ago. Wow.
Yeah.
So was that, you had to take drastic measures, didn't you?
Yeah, because the other option was just to stop going to work. You know, and
And was that an option for you?
Not really, not unless you were ill. So if you presented with the main symptoms, obviously you'd have to call occupational health. I didn't present with those.
So did you ever catch COVID? Do you think you did?
I may have. I don't know. My antibody test came back positive, which suggests that
that you've had it.
I might have had it. There's a high chance that I've had it.
Yeah.
So I suppose it's a good thing because now I probably won't get it again. That's the plan.
Yeah.
Hopefully.
Did you experience any symptoms then? If your antibody test came positive, did you have any symptoms?
At some point, I kind of lost my sense of taste and smell.
Yeah.
So at that point, I thought it was hay fever.
Okay.
Because I suffer with hay fever a lot, and those would be classic symptoms of sometimes when it's really bad. And I may have forgotten to take my antihistamines at some point. So at that point, I thought it was just the hay fever. But looking back, it may actually have been that.
It may have been. Yeah. And through that time, you carried on.
Oh yeah, I just carried on. Yeah, because then I didn't think it was that. Yeah.
I think at the beginning it was the symptoms were
coughing.
Clear. It was coughing and high temperature.
High temperatures. Yeah.
Yeah. And then if you can't breathe, go to the hospital.
Exactly.
So so it was difficult to see if you had any other symptoms.
Besides that, there was absolutely nothing at all.
So you felt fit and strong throughout.
Absolutely, 100%. Yeah,
that's good.
Yeah.
And what about so when you got home, you would then shower and change?
Oh yeah, definitely. Okay. And then just whatever it is, if I needed to cook or have something to eat, and then just carry on. You get to be a bit paranoid about everything. My washing machine was on rotation the entire time. I was cleaning everything. But you kind of settle into sort of a routine. And I remember thinking at some point that, things aren't really ever going to be the same again.
No.
I don't think.
No.
I mean, even if they announce that COVID is finished, it's gone, there's still going to be that niggling bit where you just want to be careful.
You have to. We have to.
Yeah, definitely. And stay safe. Yeah.
We're going to take a quick break and then we're going to come back and talk about work on the ward and what it was like, how it was for you guys on a day-to-day basis, caring for COVID-19 patients. Yeah. Thank you. Welcome back. Today we're speaking to Alima Audrey Mendoza, a critical care nurse at the QE hospital. And she's speaking in her own capacity, just sharing about her own experience. So thank you, Audrey. I want to just I want you to tell the audience and tell our viewers about your experience on the ward, what it was like on a day-to-day basis during the peak. That time in April when things were really bad. And we saw up to 1,000 deaths. I think that was the highest per day. How was that for you guys on the ground?
I don't think there's anything that I can explain adequately to you. But what I can tell you is it was a very sobering experience. It humbled me as an individual because you realize that, life is too short for starters because you had 27-year-olds coming in and dying from COVID. And this is someone who was probably at the pub a week ago with their friends. You had middle-aged men, family men coming in and not coming out. I looked after a cardiologist, and this was a very well-renowned cardiologist from some other local hospital. And you could actually see him taking a turn for the worst each and every time he came in. And we're talking about productive members of the community here. And especially a healthcare professional as well. And also there was the experience of taking care of our own. We had some nurses coming in with COVID as well.
Yeah.
Some of them didn't make it. Some of them did. But it's something that really humbles you. Like I said, it was an extremely sobering experience. You kind of reevaluate everything. Things that you thought were important before, you realize they're not important at all. Taking care of yourself and taking care of your family health-wise is mandatory.
Yeah.
I think as far as possible, because it was Yeah, it was
It
really
was hard.
something.
It sounds
It was
like
difficult.
it was
Yeah,
traumatic.
it was.
Someone described it as a war zone.
Oh yes, I tell you what, we have some senior members of the team who've, like, in particular, an ex-military nurse. She just kept on saying every time we went into the staff room and we were working on the same shift. She was a burns and trauma nurse before she came to critical care. And we're talking about a nurse who worked in the front line during the wars, like in Syria. She mentioned Iraq. She mentioned like most of the Middle Eastern sort of war zones. And she kept on saying, you know, I've seen the worst in the world in terms of injuries. But this COVID-19 scares me more than any war zone I've ever been to. Because it's here in UK and we can't exactly send it away. And for one thing, you don't know what it's going to do. You can't see it. It's not tangible. You can't hide from it. So if someone like that with years of experience in war zones is saying that, how am I supposed to feel as a newly qualified nurse?
It must have been really
It was
frightening.
terrifying. And I think we were just running on adrenaline at that point. We just needed to get on with it. And, you know, having to operate at your maximum effort and behind a mask was something that I don't even know how we managed to do it. It's not easy.
And did you have, you know, you were working, I've seen some of pictures of nurses with bruising.
Oh, I was about to say, a lot of bruising happened. Because the masks had to seal. So the straps would be tight. So especially for the Caucasian nurses, they would get pressure ulcers, especially on the nose. You could tell every time they took it off. So we had barrier creams and we have duodems, like these adhesive dressings that we put on. But they could only help so much. Because if you're going to come back again tomorrow to work again behind a mask, you know, it will take its toll.
And what hours were you working? Like how long were you in those in the hot zones?
Normal shifts. So we normally do 11, 12-hour shifts. And I think it would make more sense to just do a 12-hour shift at that point and just get it over with. As well, after some time, like I said, we were changing things as we got along from feedback from the nurses and everything. We would get normal breaks because normally we get about 3 breaks in a day. But as time went on, we started doing like 2-hour rotations. So after every 2 hours, you go for a half-an-hour break. After every 2 hours, you have a half-an-hour break. And that worked really well.
So it was an intense environment to work in.
I can't explain it in any way that you could possibly understand, but it was really intense. Like the minute you walked in, it's almost as if you couldn't just walk out. Because for one thing, you had PPE to put on and off. So you couldn't leave with your PPE on because obviously it was heavily contaminated. So there was the doffing and the donning, which is the putting on and the taking off the PPE. Yeah, it was really, really intense.
Wow. I want to get a picture for our audience in terms of, you know, we've seen pictures from Italy, we've seen some from America, we've seen some even from here. So you're in the ICU that you were in. What was the numbers? How many people were you looking at who were coming in and coming out? I know we just saw like 1,000 deaths. What was it like on a day? Like if you go in a shift, what was it like in that respect?
Okay, so in a typical critical care ward, you would have maybe 36 beds. So these are bed spaces that you have. So in each ward, they ended up having 2 patients in 1 bed space.
Wow, because
there were so many. So it was crammed for one thing. So this is what we were looking at. I can only tell you from my experience on the front line. And this is how bad it was at its worst. And we're talking about each patient being on a ventilator. Now, this is the maximum support you can ever give anyone. So the idea was to keep them breathing as far as possible so they don't die from hypoxia. So we had proning teams, Rumbi, and these were designated teams of consultants and doctors who would walk around repositioning and turning patients.
So proning is turning them over?
Turning them over. So you have prone position where you lie on your stomach and your chest. And then you had the supine position where you're lying on your back. So you can lie them on the side. not until they'd significantly recovered. So it was either supine or proning. And because they had ventilators, they had tubes, ET tubes, they had tapes in. And these tapes, because when you prone them and they're lying on their stomachs, they have to have their heads on the side. So these tapes would cut into them. But at some point, you know, because as a nurse, as a professional, as a nursing professional, you know, you have to prioritize your healthcare because the idea is to keep your patient alive. So the last thing you're worrying about is the aesthetics of it.
Yeah.
Okay? Because if it's keeping them alive, we'll let we had to. They had no choice. We couldn't put anchor fasts because they were lying on their sides. That would have been worse. So that was the other thing. Some of them would get infected, especially for our diabetic patients. That was one challenge that we constantly faced.
Yeah.
But like I said, it was more about priority than anything.
So it was a battle for people's lives.
Oh,
every
absolutely.
day,
Because, you know, I mean, I would be mortified if a patient died in my care. You don't want that to happen. That's not what you're there for. Okay, there are some instances where you have no choice but to withdraw support. But as far as possible, you want to keep your patient alive.
Yeah.
And you want to make sure that when you go there, you're going to give it your best shot.
Yeah. Yeah.
Yeah.
You guys did well. We clapped for you every Thursday.
Oh, yeah.
And we are so grateful to have you guys on the front line.
Oh, yeah.
Risking your lives and doing that for us. It's just been phenomenal what all of you, the nurses and doctors, healthcare workers, cleaners, everyone in the NHS
absolutely
has been absolutely amazing. And when we hear of, you know, what you've experienced on a day-to-day basis, it brings it, you know, it brings it for us. It makes it really clear.
Yeah.
How did you cope with the death of patients at such a high alarming rate?
You see, I think I was on autopilot, because it was happening that often. You know, you'd come in today, you have one patient, the next day they're not there anymore. But on the bright side, some of them did recover. You'd have some people who then move on because we had step-down wards as well.
Yeah.
Like sort of COVID rehab wards. A lot of them would go there as well with tracheostomies, which was just a matter of supportive care. If you have a trache, the worst is technically over. And then you'd have some times where you just, at first it was a bit horrifying, but it was happening so often, you know, it just became...
You became used to it.
You have to. I mean, because even on a normal ward, you have patients who die. They have surgery, they come back, they're supposed to recover, but something happens and they still die.
Yeah.
So it's one of those things that you kind of, I wouldn't want to say get used to, but you just learn to get on with it.
Yeah, because it's work.
Yeah, it is work.
It's work.
And you know, the thing is, the idea is to go in there and give it your best shot. That way, if something like that happens, your conscience is semi-clear at least.
That you've done your best.
You've done your best.
You've done your best.
Yeah.
That's amazing. That's true, isn't it?
Yeah.
It's work for us who are not in the medical. I can't imagine. I could never have. I couldn't do it. I couldn't have managed it.
I didn't think, like when I think back, I'm thinking, how the heck did I manage that?
Yeah.
I don't know. Like I said, I just took each day as it came.
Adrenaline. You said you were on adrenaline.
I think
That's
so.
what you said.
I really feel like we were just running adrenaline because it was intense in there. It was really, really intense. I mean, if you can think about non-critical care staff coming, we're talking about research nurses who spend their times behind computers and paperwork.
Everyone had to just jump in and work. Yeah, that's just amazing. And we want to talk a little bit more after the break about the nurses or the death of BME patients. There's a lot on the news about that, and also about some of the healthcare professionals from our community who died, and just thinking of some of the challenges and maybe some reasons that this could have happened. So we're just going to take a short break and then come back and just talk about that. We're talking to Alena Audrey Mendoza, a critical care nurse, who's talking about her experience in COVID-19. And we're in our final segment now, and we're just going to talk about the news and the media and what we've been seeing about the deaths of BME people that they are higher and at a higher risk of dying from COVID than other, the ethnicities.
It's a bit of a tongue twister.
What was your experience of that? Did you see that proportionally in the hospitals? I mean, we're talking about proportion because the BMEs are minorities. But what was your experience on the wards?
Well, in terms of, like you said, they are BAME nurse. Well, okay, BAME, like they are the minority, yes. But as far as nurses are concerned, I would say, okay, from the ward, speaking of patients, you would have a couple here and then, obviously, because we're already the minority. There wouldn't be as many as maybe Asians or Caucasians on the ward. So purely from that standpoint, I would say it's difficult to gauge.
So there was, there were Blacks and Asians have been classed together, haven't they? And then the Caucasians.
Yeah.
So, from the community, for example, if we just take Zimbabweans, we're not that many in this country compared to the rest of the population. So our deaths proportionally seem are higher, and the statistics say that, isn't it? But what reasons do you think could be there from? You talked about comorbidities. You talked about some of the. Do you think what did you see on the ward?
Okay, from what I saw, a lot of the patients that actually passed on from COVID, complications due to COVID, had underlying comorbidities, like if they either had diabetes or maybe even hypertension.
Yeah,
it could be a host of other diseases that they had. It was more difficult because managing their underlying comorbidities and also managing COVID would have been quite a challenge.
Yeah.
They were already immunosuppressed. And also, I think because if in trusts generally, what I've seen is a large population of the staff, the healthcare staff, are from the BAME community. Yeah. So really, in terms of proportion, it goes without saying that it would seem like that. Yeah. This is from where I'm seeing. I did not see any sort of discrimination as such, because everyone was coming to work if they were able-bodied, if they were healthy and well. They had a set of symptoms that they would say if you was presenting with either a high temperature, with coughing, sudden cough, or at some point they said diarrhea as well. But it was really high fever and coughing. Those were the two main ones.
And some people have said that if a Black person came to the hospital, they would be turned away. And if a white person came, they're treated differently. And even in ICU, we've just heard, people speaking on forums and talking on social media that people who, they don't ask enough questions. So even the treatment that people are getting is different, and there's discrimination and indirect racism on the wards even. Would you say you ever saw people being treated differently because of their color?
I don't think so at all, Ruby. There was no time for that.
Yeah.
I mean, it was so intense. The last thing you're worrying about really is the color of skin of your patient.
Yeah.
I don't think that would have been relevant at all. It was that intense.
Yeah.
You'd get in, you get your 2 patients, 3 even sometimes.
Yeah.
And then you just make sure you keep them alive.
Yeah.
Obviously, there's a treatment plan that will be in place depending on what stage of the disease they're on. So you just follow it through. I don't think, there are records you have to keep. You have to document everything.
Yes.
So if you slacken, it will show.
Yeah.
And it's on you. We have pins and those can be taken away in a flash. So from my experience, I didn't see anything like that.
Yeah.
And from my experience, I would say there was no time for that. There was no time to think.
That way.
No.
Yeah. To think even, just to think.
You just had to get on with it.
Just get on with it, yeah. And so that's good to hear, because I think people talk, there's so many conspiracy theories.
Oh, yes, yeah.
And
and things can be interpreted differently. Like you said, sometimes people don't have, they don't ask the right questions and, but you can't really, I don't think the onus should be just on one particular group and saying the healthcare professionals are the ones doing this and that. Because as far as a healthcare professional is concerned, they get a patient and their job is to keep them safe, keep them alive.
And treat them.
Exactly. If you're going to be there with your patient for 12 hours, you might as well do your best.
Yeah, that's good. That's good to hear. And the you talked about diabetes, hypertension. Some of these are, there's some diseases which are more prevalent
Exactly. Amongst the BAME community.
Our communities.
That's true, yeah.
And that seems to be one of the underlying reasons.
Yes,
I think there's a lot of research going on anyway about it. And I know some of the pages in the report were taken out. So there's a lot of debate and conversations around this and research that's being done. On another level, perhaps, you talked about the high numbers of BAME nurses on the wards, in the hospitals. They're a large proportion.
Yeah.
I want to break it down a little bit more to Zimbabweans. And the number of Zimbabweans, I think there were 29 or 30, looking at all the press releases and the reports, that there were 29 or 30 Zimbabwean healthcare professionals who died from COVID-19. And that's the highest number in terms of ethnicity of minority groups, or even just who have died, just one collective group. And I want to just talk about that a little bit more. Do you have any thoughts about why Zimbabweans would have been such a high number?
Again, it would go back to being a part of the workforce. A lot of Zimbabweans are healthcare professionals. We are very hardworking. We don't shy away from challenges. And I think we just have this resilience that we have, and sometimes it's not good for us.
Yeah.
We kind of expose ourselves. And the other thing that I noticed is, because of our resilience as well, we're not very keen on being seen as unwell, because a lot of people would have underlying health issues and not actually be aware of them until something strikes like that, and then everything takes the head. So that is one other thing that I would think personally would have contributed.
So that would be like continuing to work, because I know some people will just be saying, like having a headache,
but then you just pop paracetamol,
you just carry on, just have
go.
paracetamol and carry on and go.
That's it. That's exactly what I'm saying.
Yeah,
we are resilient.
Yeah.
We are very resilient. We're very hardworking, very ambitious as well, I'd like to think. So some things that would be taken seriously by some other people would not necessarily be a serious issue with us. I think somehow that would contribute at some point. Yeah.
And what about you as a Zimbabwean mom and nurse? Financially, do you think that's a motivation for people, that they carried on working in when there could have been financial pressure or anything like that?
Financial pressure. I mean, if you're on a full-time contract, you're obligated to carry out your contract. I mean, to work your contractual hours anyway. So it doesn't matter where you're working. If you're supposed to work 37.5 hours a week, then you do that. What I can say is, a lot of people would present with our occupational health team, for example, would have a set of symptoms, and they would say, if your temperature was above 37.5 or whatever, if you called in, then they would say, go into isolation for 14 days. If it doesn't resolve, give us a call and you go for another 14 days. So it just took one phone call for you to be put into isolation, and this is paid leave, I would imagine. So I think financial motivation, not really. I don't think it would be, because you're supposed
for agency nurses.
Exactly. But like I said, we had redeployed staff from other areas coming in. I doubt very much we had any agency nurses coming in at that point.
So in the critical care unit, it was all NHS staff, not agency.
I don't think so. I don't know much about it, but I doubt very much. If there were very few numbers as compared to other times. Other times, yeah. Yeah. So like I said, we had redeployed staff coming in, and they would take on the role of the other critical nurses who weren't available, maybe because they had presented with symptoms or whatever the case may be at that time. But as far as agency nurses, not in my trust.
Yeah. Okay.
I don't think so.
Yeah. That's good. And I think generally in the some of when people work agency, they have you newly qualified, so it's good for you to. I think with some people who've been in nursing for longer, some work agency
Exactly.
and compare. I think the remuneration with NHS. But agency staff don't get paid if they're off sick, isn't it? So I think that's one of the other reasons that's been muted around. That
Definitely.
It was difficult to stop because you don't get paid.
You still need to make that money.
Yeah.
Like I said, I'm not. When I was in it, I was just in it to
To save lives.
Yes, the logistics of it. They may have been agency nurses. I really don't know.
Yeah.
But what
No,
I
that's
do
good.
know is that you had redeployed staff coming from other areas and helping out, as well as the critical care staff that were already there.
Yeah.
So it could be, it could be not. But as far as my trust is concerned, because they have their own bank, in-house bank, and it's made almost entirely of employees that are there already on contracts.
That's
so
good.
before they actually get agency nurses, they have to find from the bank staff anyway.
Staff. Yeah.
So I'm not entirely sure
about that.
It
No,
could
that's
be,
great.
it could be not. Yeah.
Yeah. That's good. And what would you? I mean, what advice would you give to people from Zim, just general public, from what you've seen? I think you've mentioned something before. You've said we should value the time that we have and prioritize. But I want you to speak directly to people about their health, in what you've seen, because we don't know if COVID is going to come back. We don't know what else will come back, but just generally about some of the underlying conditions that people had. What would you say? What advice would you give people?
Foremost, I would say just taking care of yourself, making sure you're safe, not unnecessarily exposing yourself. I mean, you can never know, but building your immunity as well.
Yeah. And how do you do that? Eating well.
And if anything is not right with yourself, go to the doctor, get to the bottom of it. If it's going to be treated. If you can manage it. At least you know what you're dealing with.
Yeah.
But above all else, it's obviously just to be safe and, I don't know, hygiene.
I know
it's not an issue with us, but hygiene is paramount.
It's paramount,
You have to wash your hands as far as possible if you're going to go outside. Wash your hands. Have a shower if you can. I mean, it won't kill you. But yeah, hygiene. We just have to up the ante a little bit.
We have to become OCD about it.
We have to all become OCD about it. Yeah.
Yeah.
That's
so
just
health,
the way. Yeah. Keep hand sanitizer everywhere in your car. If you're going to come out, go into the shops, use it. And when you can, wash your hands. Yeah,
that's true.
Definitely.
That's great. That's awesome. And it's not the time to relax, is it?
Not at all. And I feel like it's going to be like this for a while yet. I mean, even if things totally calm down, we're still going to have it at the back of our heads.
Yeah.
So in a way, it's a good thing. But just to stay safe, really.
Stay safe. Yeah. That's great. Thank you so much.
Oh,
Thank you,
you're
Audrey.
welcome.
It's been so great chatting to you and just
Likewise.
hearing about your experience and and just talking to people about what's been happening. So that's awesome. Thank you.
You're welcome.
Thank you so much. Thank you to Audrey for sharing her experience on the front line. We've suffered a lot as a community and as a nation and we're still going through COVID-19. It was really important for us to hear from someone who's been on the front line and who continues to be on the front line. And we just want to take this opportunity to say thank you to all the healthcare staff in the NHS and in the private sector who have looked after patients, who have sacrificed their own lives, sacrificed the lives of their families by going to work day in and day out. We thank you for your commitment. We thank you for your compassion. We thank you for your dedication to your work. And we want to say, as a Zimbabwean show which is led by Zimbabwean and produced by Zimbabweans, we also want to say thank you to all the Zimbabwean nurses who have been on the front line, who have continued to work, and to those who've lost their lives We say nematambudziko, and may you rest in peace and may God be with your families. This is a somber time for us, a time for reflection, a time to be introspective and to look at our own lives, to ensure that we are healthy, those around us are healthy. Audrey has spoken about the importance of taking supplements, of exercise, of diet, of diagnosis, of if you're not well, if you've just got a recurring headache, going to the GP, ensuring that you are tested and that you get the diagnosis that you need and the treatment. We've got to look after ourselves. We've got to love those that are around us and cherish every day, because tomorrow is not guaranteed. If anything, this COVID time has showed us that tomorrow is never guaranteed. So look after yourselves, look after each other, love each other, and be kind to each other. Thank you so much for watching. God bless you.